Okay, we are going to start our mid-afternoon, mid-morning session. So we are going to have our debate on ovarian tissue cryopreservation versus oocyte cryopreservation. Our debaters are Julie Rios from the University of Pittsburgh and Dror Meirow from Israel. So Dr. Julie Rios recently joined the faculty at the University of Pittsburgh Medical Center as the Division Director of Reproductive Endocrinology and Infertility and the clinical lead for the Center for Reproductive Endocrinology and Infertility. She is an associate professor here, and prior to her time here, she served as the fertility preservation lead at the University of Cincinnati. Cincinnati Children's Hospital Medical Center. Dr. Dror Meirow is joining us remotely from Israel. Professor Dror Meirow is the director of the Morris Kahn Center for Fertility Preservation, Division of Obstetrics and Gynecology at Sheba Medical Center, Tel HaShomer, Israel. He is the director of gynecologic care and breast cancer patients at Sheba Medical Center. He is a full professor at the Sackler Faculty of Medicine and former president of the International Society of Fertility Preservation. Professor Meirow received his MD from the Hebrew University, Jerusalem, Israel. He then specialized and practiced as a senior physician in obstetrics and gynecology at Hadassah University Hospital. I'm pleased to welcome you, Professor Meirow, and we are thinking of you and your family, and we hope that you are safe.
Thank you very much for this kind introduction, and I hope this time will not have any technical problems because I will be only speaking. Thank you.
Okay. Thank you so much for having me and Dr. Dror do this, Dr. Meirow do this debate. So obviously we know that when we talk to patients for fertility preservation who have ovaries, that we have the option of oocyte cryo or embryo cryopreservation, as well as ovarian tissue cryopreservation. But sometimes it comes up as which one's better, how do you decide which one is the one that you should offer the patient, which one's best? And so I'm gonna take the side of, oocyte cryo, and I'm gonna just start quickly to review that, some of the pros of oocyte cryopreservation is that patients there might be more centers around where this patient is receiving care that are offering this service. It's a standard of care technique. It's minimally invasive, doesn't require a major surgery. Overall, in the world, there's potentially more live births from oocyte cryopreservation. And this may more allow for pre-implantation genetic testing if that's needed based on the patient's age or on a gene that they carry. Some of the cons would be that it takes about 2 weeks to complete. That may delay treatment. They may just possibly get one attempt at pregnancy from this oocyte cryopreservation, and so if they have a poor response, that may not be optimal for the patient. Cost, in some places, this can be very a barrier for many patients. Also, we can't offer this in prepubertal patients, and there's the complication of ovarian hyperstimulation that may complicate future surgeries or treatments. So I'm going to turn it over to you to talk about the pros and cons, Dr. Meirow, for ovarian tissue cryopreservation.
Okay. First, it's important that Fertility Preservation Center will have both options. So one center will be able to advocate for both indications. The pros for ovarian tissue cryopreservation is, as we see it now, after doing more than 80, almost 85 transplantation of ovarian tissue, is that it has proved success. And actually, the success rate in our hands is very good. In our hands is even better than oocyte freezing, but it can be the same. It makes returns endocrine function. It makes possible to have repeated pregnancies. As we saw yesterday, we have up to 4 childbirth after after a transplantation of frozen thawed ovarian tissue. But what is also important is that you can do it on a sick patient. And the most important, we discussed it also yesterday, you can do it after initiation of chemotherapy. So if patient's condition is not good and you start chemotherapy before making procedure of fertility preservation, the only option is freezing ovarian tissue and not IVM or IVF or whatsoever. It is suitable for young children, even babies, who perform it from the age of 1-year-old babies for certain indications. So it's very feasible for very young people. Above in older patients, as oocyte freezing the yield decay, also with ovarian tissue, our upper limit is the age of 40. I know centers that will do it even at a younger age, will stop like 35 or 36 because the success rate is lower. It's invasive. You have to do a laparoscopy, but on the other hand, as we'll see afterwards, with a certain health condition, stimulation is much more risky than doing half an hour under medical care doing anesthesia. And of course, is the need for another operation for transplantation and the risk of malignant cells that we discussed yesterday. And it's not experimental in many countries nowadays. I know in Denmark, I know in Israel, and I know in other places that ovarian tissue cryopreservation is covered by health medical care in Israel and also in other countries.
So I think this was outlined here, can be performed rapidly, doesn't delay medical therapy, sick patients, healthy patients, or healthier patients, and it allows for both clinical pregnancy and live birth. For oocyte cryopreservation or embryo cryopreservation, I think, there was this myth that we needed to wait for the next menstrual cycle, and that's what we all did. I mean, when I was in fellowship, that was a routine. We have to wait, and so then if we were telling oncologists it was 4 weeks out, it was much more concerning than 2, and I think we have really good data that we can really do this at any time in the menstrual cycle. We can also potentially do back-to-back cycles in certain patients if they are able to have that, 4-week delay between a surgery and initiation of chemotherapy, and some of that duostim or kind of back-to-back follicular starts are options for patients. And I think reproductive endocrinologists need to get more comfortable with offering these protocols and kind of thinking of those worst case scenarios. Maybe we only get a few eggs. What's our plan to try to optimize these options before patients start their treatment? So I put up this, and I'll give my opinion, and then I'll ask for yours. But this was a study from 2018 from a single center where they looked at their patients that presented for oocyte cryopreservation versus ovarian tissue. And they found that clinically they had more pregnancies and live birth with oocyte cryopreservation versus ovarian tissue. But there's been no direct comparison, and it's hard to look at, age, ovarian reserve prior to this. But I think one important point of this is just that less than 7% of patients have come back to use their reproductive tissue. So this was, one center. What has your experience been, Dr. Meirow, with oocyte cryo versus ovarian tissue? What do more people come back to use? Are you seeing similar pregnancy rates or one that's better?
Well, the people who come back is about, I think, 10% for both procedures due to several reasons. Among them is that fertility might continue after the chemotherapy, or there is no need, or due to medical condition. About 10% of the patients after ovarian tissue are not surviving. But this is the recurrence rate, and I don't think it will change much, and it doesn't matter which procedure you choose. About the success rate, I told you yesterday that we analyzed our data after having 50 pregnancies, that the success rate is about 50% of pregnancy and 40% of live birth with ovarian tissue, with repeated pregnancies. We did not summarize our results of oocyte freezing and thawing with oncological patients. And I'm sure that there are centers that might have even better results. But the important thing is to choose for each case the right option, and if possible, even to do both options.
So that kind of brings us to our goal for this, was to really kind of highlight some cases and how we might approach them. And so I'm going to read the case, and then we'll each kind of talk about our upfront fertility preservation counseling, but then each case maybe have some unique points to it. So this is a 25-year-old with ovaries who presents after a diagnosis of ER/PR, HER2, or triple-negative breast cancer. The plan is for chemotherapy and surgery, and she wants to discuss fertility preservation. And the plan will be for surgery up front and then chemotherapy to follow. And so the goal is to counsel on all options, including ovarian tissue and oocyte cryo. The patient asks about both. And so how would you counsel this patient she's young, we assume she has good ovarian reserve, but let's say she has an AMH of 2. How would you counsel her for OTC if you were seeing this patient? Dr. Meirow.
Okay. The patients with breast cancer, almost all of them will go for oocyte freezing because of several reasons. Even if they go for neoadjuvant chemotherapy before operation, they also will go for oocyte freezing because they are young, the oocyte yield is good, and we have the time. The patient medically, she is healthy, and at this age and up to the age of 31, 32, the results will be that actually after ending her treatment, her ovaries will function good, and she can actually conceive either spontaneously or by assisted reproductive technology with her own oocytes. As she is hormonal negative, there's about 30% chances that she will be BRCA carrier, and this is also a point to mention when you choose between ovarian tissue cryopreservation and oocyte freezing, and maybe she will want to make genetic testing if the embryos are positive or negative. Actually, you need a lot of oocytes for this, and I don't always recommend for this. Nevertheless, actually, all breast cancer patients will go for oocyte freezing, except two options. One, if the patient is pregnant or associated with pregnancy, the results of stimulation immediately after pregnancy or abortion is low. If the patient needs to start chemotherapy during pregnancy and then you want to preserve fertility, the only option will be, as I said before, only ovarian tissue. So these are the cases that we perform ovarian tissue, but all the rest of the cases will go for oocyte freezing. And another option that sometimes patients come to us, if the stimulation was not successful and she needs to start chemotherapy now, and she asks, please, can you also make another procedure for fertility preservation? Then we also consider ovarian tissue cryopreservation.
Yeah, and I think I agree with that. So I do, when I see these patients, always counsel for oocyte cryo, and based on their ovarian reserve, we'll try to time 1 or 2 cycles based on our time from their age, their ovarian reserve, and our time between surgery and chemotherapy, so that we can optimize the outcome. And I agree that, if the patient is pregnant and then going to have to undergo a termination or delivery, and that time from pregnancy till their pregnancy hormone level becomes low and negative can be quite long, depending how far they're through pregnancy. And there's been a few case reports and things that I've read in the literature, as well as anecdotally from colleagues, that you try to stimulate a patient that still has pregnancy hormone from a pregnancy, they can have very severe hyperstimulation and complications. And so it's really not recommended until that pregnancy test is negative, which can take anywhere from like 2 to 6 weeks, depending on where the patient is, how quickly that level drops. And so I also agree that that would be an instance where ovarian tissue for this patient may be a better option, or proceeding, depending on the risk of the therapy, that may be, I'm not sure what you meant, that may be something that we just observe and watch, and don't, if the patient is not interested in, ovarian tissue at that time or for surgery, but that would be also a case. I also think the patient that maybe stimulates poor, where we don't get a lot of oocytes and we don't have time to do another cycle, I think it's that counseling for ovarian tissue cryopreservation. But if the patient is young, does have the genetic mutation, then again, one of the limitations for OTC that I see and transplant is doing PGT in the future, because we don't always get a lot of eggs from that tissue. And so for those patients, I strongly would recommend proceeding with oocyte cryo or embryo cryopreservation. So our next case is an 18-year-old with ovaries who presents for counseling after newly diagnosed AML. She had menarche at 12, has regular monthly periods. Initial treatment is with no alkylating agents. So again, this is a leukemia patient. The question will be with the oncology team, like, do we have time? A lot of times we don't for oocyte cryopreservation. If this was maybe a patient that was relapsed after initial treatment before a transplant, then that may be a different case. They're maybe not as sick. But it's deciding if we would have those 2 weeks, even though the no alkylating agents is a low risk, there is always that chance that they could relapse. A lot of times maybe genetics aren't back to determine if they're going to need a transplant after this initial treatment. And so I would potentially try to offer oocyte cryo as my preference, just because of that risk of reseeding. So even though we do have these great protocols to look and screen for MRD negative, what if they take that's their only option and they're not MRD negative, then they don't have any other option. And so that would be my approach, would be to see if we have the time before that initial chemotherapy starts. Dr. Meirow, are you still with us?
Yes, of course.
Okay.
So what I have noticed that in some places and many of them are coming to us, and it's actually can be very risky, because you can get into 0 platelets, or you can get blood counts that are highly deteriorated, and you find yourself in the middle of stimulation. Nobody with leukemia can know what is the deterioration rate. So it happens quite frequently, and I quite hesitate with this. So as I mentioned, our protocol is to let them start the chemotherapy, and if they are not high risk and will need only the first line of treatment, actually their fertility will not be affected. And if some of them, and actually more than 40% to 60%, depending on if it's AML or ALL, will go to bone marrow transplantation, then we perform, when the bone marrow is clean, will perform ovarian tissue cryopreservation, and of course check for MRD. I think at this time for the patient is much more safe procedure.
So this patient does end up carrying like a chromosome rearrangement that ultimately will undergo a bone marrow transplant with busulfan and Cytoxan treatment, and so did complete the initial rounds of chemotherapy. How do you counsel that patient of the likelihood that they will use their tissue? So let's say their bone marrow aspirates MRD negative, and when you're seeing that patient in front of you, that's, I think, a question they want to know, is how likely it is that I will use this tissue. From your experience, how do you counsel them?
Well, if a patient is going to bone marrow transplantation, I tell them that about 90% of chances that they will they will come menopausal and lose their fertility. So the chances they will come and ask for the tissue is quite high. And this is what we see today. Many of the leukemia patients are coming back. They are much younger, and they will suffer from total loss of ovarian reserve. So many of them will come back.
So I think we talked about this, that the patient is acutely ill. So with short times at 48 hours for any leukemia patient, if they are sick, we wouldn't offer any oocyte cryo, and we would wait to see that direction. If the patient was a relapsed AML that had not had any recent chemotherapy and was planning bone marrow transplant, patient might be not as unstable. The relapse was determined during a routine follow-up. Again, I think it's working with that oncologist, looking at the platelet counts, all the markers, white counts, to decide if can they undergo oocyte cryopreservation. But otherwise, I think the protocols that we have for ovarian tissue cryopreservation, which is, at the time of dissection, making sure that you have tissue that you can test in the future. This is based on some of the papers that Dr. Meirow has written, but just making sure that you have those options for blood-stained tissue, histopathology, IHC in the future that are disease-specific, PCR, and next-generation sequencing for minced blood-stained tissue, and cytogenic markers can also be tested. And then prior to transplant, thawing that blood-stained tissue, performing that testing, and thawing the cortex also. And I think you went through that pretty well yesterday during your talk. But I guess my question to you again is, how many patients are unable to use their tissue with this protocol that you're finding?
Well, I showed yesterday that we have some patients, not so many, but we have. Of course, we have. I cannot give percentages because it's too early to say this. But yes, there are cases that you find a residual disease in the ovaries and you will not use it. I would like just to mention that it's important that you will be able to put your hands on the leukemia cells of the original disease, which actually all hospitals keep today.
Okay. Our next case is a 28-year-old married nulliparous diagnosed with cervical cancer. The patient is noted to have a 4-centimeter bulky mass of the cervix. The oncology plan is for chemotherapy and radiation, pelvic radiation. Patient presents for her FP consult. You counsel the patient for all options, including ovarian transposition, ovarian tissue cryopreservation, and oocyte cryopreservation. So for this patient, I think my first approach would be to evaluate her and do a speculum exam, physical exam, see are we able to access the ovary with the retrieval needle. Would we need to consider a different approach? Would we need a transabdominal approach? And do we have those, does every clinic have that resource? And if you don't have that resource, can you refer to someone else with that resource? So a lot of times this can be a concern that the cervical mass might preclude transvaginal retrieval. And so again, having those options for considering, sorry, is a Zoom still on? Okay, all right, I'm up here by myself, so I'll present both sides of this. This was a case that he actually had. I think it's important to know your limitations in your clinic, and if you aren't able to perform a transabdominal retrieval, but that could be an option for the patient, is to refer those out. So this patient actually did undergo IVF and had an abdominal oocyte retrieval with 6 mature oocytes, resulting in 5 embryos cryopreserved. but the patient desires 3 children. And so that becomes part of that trick as well, is, fertility preservation may not just be enough for 1 child. That person may have wanted a big family. And so, what would the options be to counsel? So again, I think it depends on your time. Could we do a second retrieval? If I knew that up front, could I have planned to stop stimulate, do the retrieval 5 days later, start another stimulation? Possibly. And I think that would be my approach initially, because obviously with ovarian tissue, there can be, concerns as well with cervical cancer. So we're on the cervical cancer case. And so we just presented that the patient had her abdominal oocyte retrieval and 6 eggs collected and 5 embryo transfer. And so the patient wanted 3 kids though, and only has 5 embryos. So what other, would you offer this patient ovarian tissue cryo, and what do you think the benefits to that as well for this patient are?
Okay, cervical cancer is a complicated case. It really depends on what you find. Actually, today I was treating a cervical cancer patient, and one of the problem, we go for egg retrieval, and one of the problem is that during that time, some of them are bleeding, heavily bleeding, and you had to take care of this because sometimes they need to start the radiation fast in order to stop this massive bleeding. The question about if you can go and how you can aspirate the oocytes is difficult, especially if the patient is not lean. To go through abdominal aspiration, always you get less oocytes. I can recommend something. We have not published it, but we have performed it several times for such cases and for other indications, is to do rectal aspiration. And we do it quite successfully. It's very similar to vaginal, and somebody that makes through the vagina can do it through rectal aspiration, and it's very, very successful. About ovarian tissue freezing, we do it in cases when we perform oophoropexy. Then always we'll take part of the ovary for freezing, because there are chances that the oophoropexy will not, the ovaries will not function afterwards, maybe because of a technical problem, vascular injury, or scatter radiation. So always we freeze ovarian tissue. Transplantation of ovarian tissue in such cases technically is also challenging, because after radiation to the pelvis, the vascularization is very poor, and it's not easy to make transplantation there. The other options of transplantation out of the pelvic cavity did not show success during the last years that were attempted by other centers. And one of the options that we performed is to make an operation which is quite big. It's not easy. It takes time to re-put the ovary back to the pelvis, to open the attachment of the ovary to the eye in the abdominal cavity and put it back, and then transplant the ovarian tissue, because of the good vascularization there, to the ovary that is not functioning. We perform a oocyte retrieval for such cases, and I have to say, and you will say something different, I know, that until now it was not successful. We didn't get any case of a pregnancy after a transplantation of ovarian tissue in cervical cancer patients, because I think it's very complicated. You need to find the good location for transplantation. You have to aspirate the few eggs that will grow there, if they grow, and then you have to put it in a surrogacy. So there are many steps to overcome. And as far as I know, until now, there are no publications in the world of success of ovarian tissue transplantation after cervical cancer. So the best shot will be if you can get embryos. So we try a lot to aspirate oocytes before doing anything else.
And also, like, surgery in these patients after radiation can lead to more complicated surgeries. So I think that's a risk for the OTC as well. And then again, the patient needing to use a gestational carrier, given that with OTC, we don't always get as many eggs after transplant. When a gestational carrier is involved, I do tend to favor oocyte cryopreservation. And so for our last case, this is also a patient.
Sorry.
Yep.
Can you continue with the case that you presented?
Yeah. With this one, so you
Yes.
you had mentioned that you guys did do a transplant with histopathology showing 15 primordial, 6 primary follicles, and 1 secondary. And then you did malignancy staining with NNF116 immunostaining negative, and you got tumor board approval. Correct for this patient?
Okay, I thought that you got pregnancy at your center, so sorry, I didn't understand. Okay.
Okay. Should I go on to the last case?
Okay.
Okay. So 19-year-old with ovaries affected by Hodgkin's lymphoma plans therapy and presents for FP prior to chemotherapy. So for this patient, initially, again, her risk is quite low with most fertility preservation cases or treatments or cancer treatments. But again, if there's the counseling I think I provide these patients, if there is a relapse, then the next chances that you may go on to ovarian tissue, to a transplant. And so then at that point, you've had chemo. We're not going to be able to perform egg freezing at that time. And so if the patient is stable and we're able to perform that oocyte cryo prior to chemotherapy, I often will. Things that are of concern sometimes is patients can have large mediastinal masses, which can be a concern for our anesthesia teams, and where are we going to be performing the oocyte pickup or the egg retrieval. So we're very lucky at our institution here is that any of our patients that can't be done in our surgery center can now be done in our hospital. So we have portable incubators. We harvest the oocytes without an embryologist in the room, which is very scary. And the tubes just get transported out to our IVF center. And about an hour later, I send my text, how many did we get? And so far, we've done 4 of these cases in the past year, and it's been very successful. And then the patient can go on to perform have her chemotherapy. And then if she would relapse and go to transplant, she's already done some sort of fertility preservation, but then often could also proceed with other options too at that point if she wanted to also do ovarian tissue cryo. So what would your approach be if this patient came to you prior to chemotherapy? Would you offer egg freezing, or would you wait to see if she got more aggressive treatment?
Okay, Hodgkin disease is very common. A lot of our patients are Hodgkin lymphoma patients that are coming. It's very common disease during reproductive age. So if the patient is younger than 24 and she's going for the first line chemotherapy for Hodgkin disease, meaning ABVD or something like this, we will not perform any fertility preservation. If she's older, above 25, or she's going to second line chemotherapy, like the BCOP protocol, then the chances of ovarian damage is real, and with the BCOP is very, very severe, and some of them will go for ovarian tissue cryopreservation. So this is the risk. And the other thing is taking into consideration the mass. We look very much for the CT scan and the echo. And some cases you can see that the lymphoma actually almost obliterate blood vessels, the superior vena cava or something like this. And in such cases, we will not perform oocyte freezing. We had some cases that came for us from other hospitals that performed oocyte freezing and stimulate those patients. And actually, we saw cases of blood clot creations and can be very risky. So what we do with the Hodgkin lymphoma patients, if the mass is not critical, of course, what you said is an option. But if there is a big mass in the thorax, and we'll see for what happens with the blood and what goes with the heart, then we will not do any fertility preservation procedure. We let the patient go for the first line treatment, and then we'll monitor the mass. And with Hodgkin disease, the mass actually goes away very fast. And then after the first or the second line of chemotherapy, we'll perform ovarian tissue cryopreservation.
So I think just to kind of wrap up, and then we can take some questions. I mean, I think one of the big differences I see in my counseling versus yours is that you have the comfort of your history and your experience with OTC and your success that, you know, you're doing those surgeries you're quoting. And I think here in the United States, OTC is still very, except for in a few centers, ovarian tissue cryo and ovarian tissue transplant is still not routinely done. And we don't have those success rates. And so I think my counseling is always, you know, can we get oocytes? Can we do that? Do we have that time? And so that's, and I'm also, you know, I think that's my bias, and I can admit that, but I still know that the ovarian tissue is an option and that there are great clinicians and researchers out there that are helping those of us that don't have this experience, you know, have these opportunities for our programs. What are your thoughts on, you know, the differences of our counseling here?
Well, that's what I mentioned at the beginning, which is important that fertility preservation center, a tertiary at least, should have all options in hand. And you need to feel convenient with all the procedure. So then you take into account only the patient's benefit and not what you have in your hands, because you should have in your hands, and this is what we recommend, to have all options in your hand, and then according for each patient, you give them your best option.
Thank you so much. I think we'll take any questions for myself or Dr. Meirow.
I would like to point out a few things I've said earlier in this meeting that apply to this debate that I haven't heard. Firstly, you quoted a 40% success rate with egg freezing and a 34% success rate with ovary tissue transplantation. And that is really not what we're experiencing, and I've explained why. We're up to 80% now, pregnancies leading to live babies from frozen ovary transplants for cancer patients. And I think the major reason is for the surgical approach and not relying on IVF, because IVF is problematic with these cases, but doing the surgery in such a way that the fallopian tube can easily pick up the egg from ovulation, and they get pregnant spontaneously. So the pregnancy rates that we're talking about really don't have to be valid if the approach is different surgically. And the next point is that we can get as many eggs with IVM now from the ovary tissue when we take it out as we could with ovary stimulation. So why ovary stimulation? Why not just take out the ovary, freeze the cortex, and at the same time get as many as 12 to 20 good quality M2 eggs just from IVM? These eggs have been studied by Klaus Anderson. There are pregnancies with them, and they're normal euploid eggs, 67% euploid. And I just think that solves a huge number of problems that come up in all of these cases.
I thank you for your comments, and I agree. I agree that those resources, if we had them, and you know, for all patients to be able to go to a center and get their ovary removed here in the U.S. and then also have that sent for IVM, but I don't think that it routinely is not available. So it's great that you have that in St. Louis, but not every patient's going to be able to travel there. And I think those are the goals that, you know, this society and other groups can help us kind of advance that technology so it's more widespread offered here in the U.S.
I agree with that for the present status situation, but that can be changed very quickly, because the surgery I'm talking about is relatively easy. You just got to talk the gynecologist into doing it that way. It's very simple surgery. And the IVM is incredibly simple now based on Klaus Anderson's work and the work from Hayashi, it's really simple, ordinary media. You don't even need IVM media. It's very, very simple. So I think for the future, these points are very clear. And I'm not against overstimulation to get eggs, because in some cases that's what you have to do. But I think for the majority of cases you presented, you could just take out the ovary, have ovary tissue frozen. If they've had prior chemo recently, it doesn't matter because the primordial follicles will have survived, and at least you can do the ovary transplant even if you can't get eggs. And if they haven't had prior chemo, you can always get as many eggs as you could by stimulating them. And if they've had recent prior chemo, you're not going to get any eggs when you try to stimulate them anyway. So I think that's the future, and I would hope that next year when we have this meeting, more people will have that kind of experience.
Thank you, Dr. Silver. Next question.
Hello, thank you so much for the brainstorming session. It was wonderful. My question is going back to the first scenario that you explained, 25-year-old triple-negative breast cancer with BRCA mutation. But my concern is in BRCA1 mutation, when there is a 40 to 45% risk of ovarian cancer by the age of 70, should that not prompt us for ovarian oocyte cryopreservation rather than OTC?
I'm sorry, repeat your question.
So in BRCA1 mutation carriers, there is a 40 to 45% chance of ovarian carcinoma by the time they reach 70 years. So does this risk give us an edge over oocyte cryopreservation than OTC?
Yeah, I mean, I think that is a concern with those patients, because a lot of times once they've completed childbearing, they'll undergo a prophylactic bilateral oophorectomy. And so if they're freezing ovarian tissue and you're putting that back in, you have to be able to potentially access that tissue to remove it in the future. And so it's additional surgery. And I think that's, both of us kind of had the approach that, except for in these very rare cases, our approach really is either oocyte or embryo cryo up front for these patients.
But Julie, could you not remove the ovary and then retrieve oocytes from the ovary in those patients with breast cancer with the BRCA gene, as
So
opposed to
you're asking-
transplanting the tissue back?
I mean, if you would be able to, oh, you mean for the OTC?
Right, so for breast cancer, BRCA positive, taking out an ovary before chemotherapy, doing IVM, retrieving oocytes, and then not having to ever put that tissue back.
Correct. I mean, I think, again, once that is more routine and offering, then that's a great solution for those patients. But again, I think it's also looking at their age, their risk at the time for maybe you wait at their chemo is not going to be, a significant risk. Doing some egg freezing, potentially for PGT, that they may want to do anyway in the future, and then deciding if that ovary needs to come out.
Thank you.
Thank you. Last question, please.
Thank you so much for an excellent, very practical presentation, but maybe next year we should think about like 3-arm discussion. It means oocyte cryopreservation, OTC versus combo. And I'm actually referring to the paper published by Dones and Dolmans in 2014, when they started the stimulation, and on day 1 or 2 of the stimulation, they did laparoscopy and ovarian tissue cryopreservation. They have shown on a small group of the patient that it did not affect the outcome and the number of the eggs and normal embryos they got during the IVF process. So maybe this is the solution for the patients who do not have a lot of time, and we cannot have like a month to, let's say, do IVF, two IVF cycles. So we will have some eggs. If that will not work, we'll obviously send them to Dr. Silbert for wonderful OTT, and they will have like a secondary layer of protection of losing their fertility.
Yeah, that's a great point.
Thank you.
That is a great point.
I have a question for any of the oncologists. Are we really, truly not able to support the patients with leukemia for the 9 to 12 days that would be necessary for oocyte stimulation? I've seen it done at our institution with steroids and other supportive agents. Is there any oncologist that wants to comment? I know Jen made that comment earlier, but are we truly sure that there isn't an opportunity to stimulate in patients with leukemia by supportive measures?
All right, I hate coming up to these microphones here, but I'm Karen Burns. I'm an oncologist in Cincinnati. And yeah, I think theoretically you could, but I think there's a real risk of bleeding. There's a real risk of infection. And these patients who come in with either a low ANC or neutrophils and lymphocytes that are not functionally working are always at risk of infection. And so knowing that they have leukemia, waiting 10 days, if something were to happen during that time, it could be catastrophic. So I think you would, certainly there are exceptions to every rule in medicine, but in general, I think you would have a hard time finding an oncologist who would be comfortable delaying like that. And that's without even considering the risk of the therapy and whether that therapy is going to place them at high risk or not. Most of our upfront leukemia protocols, either AML or ALL, do not put our patients at high risk of gonadatoxicity. So that also weighs into it.
I think I've just often considered, patients don't have leukemia today, right? They usually have had some signs for a while. We meet them today and we say we immediately have to start therapy, but obviously by the time they present, they're sicker than when they initially began having symptoms maybe months before.
Yeah, and we usually don't have a lot of patients to wait around and get them started because, like you said, they've had their leukemia for weeks to months, so they've been sitting around functionally neutropenic and at risk of bleeding. There's also that risk of clotting too, due to their active malignancy, and then the therapy once we start. But so you're just walking a tightrope, and you don't want to fall off.
Yep. Perfect. Thank you. Okay, I don't want to be that person, so we're going to move along. All right. Thank you, everyone.
Thank
Let's
you.
give a.
Thank you very much.